Okay, so let's start with our questions now. Let me look at question number 1. Yeah. So what is this question saying? Let us look at question number 1. Just a minute. I'll mute myself. Okay, yeah. So let's start with this question. What is this question? A 12-year-old child presents with swelling of eyelids. So very important. The swelling of eyelids is periorbital edema, isn't it? Periorbital edema, most likely to be a renal. So commonly renal edemas are periorbital in nature, but that doesn't mean anything. But yes, I'm keeping that in mind first. Okay. Then next, decreased urine output. So now definitely I'm suspecting with this history, definitely I'm suspecting there is a renal problem, isn't it? So clinically I'm suspecting there is renal pathology involved. So decreased urine output for last 2 days. So basically there is oliguria happening. So patient is having oliguria and also edema, swelling of the eyelids, right? Then further history. What else is given to us? Let us look at further history. Physical examination shows pulse 88, which is okay, normal. BP 146/90. So there is hypertension. So let me write what all features are there. There is edema. Clinical features I am writing. Edema is there. Oliguria is there. And hypertension. So there is hypertension also given to us. Routine urine microscopy shows RBC and RBC casts. So it is misprint here. It has not. It has become cases. Casts it should be. So there is RBC cast. So what are you thinking? The moment I see RBC cast, this will suggest me it is glomerulonephritis. Glomerulonephritis. So patient is having a glomerulonephritis with oliguria and with hypertension and hematuria. All of them. Definitely I am now suspecting. Yes, all this is making me suspect it is a acute nephritic syndrome. We studied this, isn't it? So what is acute nephritic syndrome? Acute nephritic syndrome will have oliguria, azotemia, all those things, right? Okay, that is what is a manifestation. There is another condition, nephrotic. Nephrotic syndrome will not be having hypertension, will not be having oliguria, will not be having RBC cast. Nephrotic syndrome, in fact, will be having albuminuria. That will be happening there, right? Yes. So next, further history. The parents say that child had skin abscess 2 weeks back, which healed on its own, on their own. So child had skin abscess 2 weeks back. So this could be query skin abscess query pyoderma. Okay, so or not queried pyoderma. If there is a skin abscess, it is a pyoderma. Pyo means pus and derma is pyoderma, skin, right? Pyoderma. So now what is your diagnosis? Now I can understand this is 2 weeks back. Query, it could be a streptococcal pyoderma. Very commonly this is what is happening. So streptococcal pyoderma, and that will lead to nephritic syndrome. So my diagnosis, what is my diagnosis here? Is post streptococcal glomerulonephritis. Post streptococcal glomerulonephritis or a post infectious glomerulonephritis. So answer to this question is option C. Option C. So I hope all of you got this question now. Guys, please use the chat box and please respond to me. So I hope all of you got, guys, this. Okay. Yes. So this is your PSGN, post streptococcal glomerulonephritis. Yes, or post-infectious glomerulonephritis. In India, streptococcus is a common infection that causes it. In other places, it can be any other infection as well. Next, let me look at the next question now. Question number 2. Question number 2. Which of the following is not one-liner question, not a feature of nephrotic syndrome? Which is not a feature of nephrotic syndrome? Hypertension. Yes, it is not a feature of nephrotic syndrome. Hypertension is a feature of nephritic, isn't it? Hypertension is feature of nephritic syndrome. Oliguria is also feature of nephritic. Nephritic syndrome. Azotemia is also feature of nephritic. So all these are not features of nephrotic syndrome. What are the features of nephrotic syndrome? Let us understand nephrotic syndrome features. Patients will be having NSRCA, generalized edema. We understood the mechanisms also in the class. There will be NSRCA happening. There will be massive proteinuria or albuminuria. Massive proteinuria. NSRCA will be there. Then there will be hyperlipidemia. Lipiduria. Hyperlipidemia. Lipiduria will also be there. And there can be thrombotic events. Thrombosis can be happening. These are the manifestations of nephrotic syndromes. Right? Next, question number 3. Let us look at question number 3. What is this question now? A 52-year-old diabetic patient. So he's a diabetic, presents with periorbital edema. Again a renal edema. Urine routine shows albumin 3+. See, the moment urine routine is showing albumin 3+, I am going to suspect what? In kidney, I am suspecting it. I'm not suspecting, it is a feature of nephrotic syndrome, isn't it? So this is a feature of nephrotic syndrome in kidney. And there is no RBC. That confirms that it is nephrotic, not a nephritic. Next, blood work shows decreased albumin and hyperlipidemia. All these are towards what? Nephrotic only. So my diagnosis, this patient is having diabetes mellitus is there, and he is now suffering with nephrotic syndrome. Commonly, diabetes leads to, if you remember, FSGS, which leads to nephrotic syndrome. Diabetes will lead to nephrotic syndrome by FSGS, focal and segmental glomerulosclerosis, isn't it? Yes. So what is the question asked? A renal biopsy is likely to show. So what will renal biopsy show? No change in the glomeruli. This is not the answer. This will be seen in minimal change disease, isn't it? So this will be seen in minimal change. Minimal change doesn't happen at 52 years. It will occur in children. Sclerotic glomeruli, that is what will be seen. In diabetes mellitus, diabetic nephropathy will be there. Yes, manifestation, histological manifestation of diabetic nephropathy is nodular glomerulosclerosis. Nodular glomerulosclerosis. Nodular glomerulosclerosis are also known as Kimmelstel-Wilson lesion. Kimmelstel-Wilson lesions. KW lesions are seen in, okay, crescent shaped structures. That is also not the answer. This will be seen in RPGN or crescentic glomerulonephritis. Wire loop lesions will be seen in lupus nephritis. This is not a lupus nephritis, right? Yes, so this is a diabetic nephropathy which will be leading to FSGS. Next, question number 4. Let us look at now. What is this question? Question 4. Okay. 45-year-old patient was diagnosed of stroke. Okay, so 45-year was diagnosed of stroke. Okay, too young for a stroke, by the way. 45 is very young for stroke. Examination shows BP is 150/90. We can see there is hypertension. Definitely that is the reason for the stroke here, I guess, right? Urine examination shows RBC in urine. Okay, the moment there is RBC, I am suspecting query renal cause, or it could be query urinary tract pathology also. Urinary tract pathology. Serum creatinine is increased. That means now I am suspecting mostly it will be a renal cause. Less likely to be a urinary tract pathology, isn't it? Yes, so it is more likely to be a renal cause now. Next, further history suggests that patient's mother also died of stroke at early age. So patient's mother is having a stroke at died of stroke at early age. So if you are suspecting, so now query, I will suspect, if this is the case, query historically I will suspect with this family history, query autosomal dominant condition, or basically I'll suspect a dominant condition, most likely an autosomal dominant, right? You start suspecting an inherited condition. Which one of them is likely to be? So what all have been given? Patient is having hematuria, hypertension and stroke. Only 3 things have been given to us. So these are the 3 things. Which one? Alport syndrome. Alport syndrome unlikely for two reasons. One, this is more likely an autosomal dominant inheritance we are suspecting, whereas Alport is an X-linked dominant condition. Okay. Okay, and Alport classically will not have severe disease in females. So here mother has died because of the disease, right? And Alport will have more of other like lenticonus, all those things will be there in Alport. Next, von Hippel-Lindau, that is not the answer. VHL will have polycythemia, RCC will be there. Here there is no polycythemia, no RCC also. Tuberous sclerosis is also not the answer. Tuberous sclerosis will have angiomyolipoma, kidney tumor, angiomyolipoma, and cortical tubers will be there. Answer most likely in this would be a polycystic kidney. Yes, correct. Polycystic kidney, especially a adult onset or autosomal dominant polycystic kidney. We are not suspecting autosomal recessive. Autosomal recessive mostly undergo death in early infancy or in early childhood, isn't it? So ADPKD, which will have a berry aneurysms in the brain, that might be leading to stroke. There might be multiple cysts in the kidney and other things, and that is leading to such a manifestation. Of course, hypertension is because of multiple cysts in the kidney, that will lead to hypertension as well. Right, guys? Yes. Next question. Let me look at next question now. Question number 5. What is the question number 5 here? Rapidly progressive glomerulonephritis is a complication of. So RPGNs, if you remember, they are also known as histologically crescentic glomerulonephritis, because there will be crescents seen in the biopsy. So crescentic glomerulonephritis. So examiner is asking you, crescentic glomerulonephritis is a complication of nephritic syndromes. So remember, it is a complication of nephritic, not nephrotic syndromes. So crescentic glomerulonephritis is a complication of nephritic syndromes. Acute nephritic syndrome can progress to RPGN or acute renal failure. So RPGN is nothing but acute nephritic syndrome progressing to acute nephritic progressing to acute renal failure. That is what is your RPGN, rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. Next, question number 6. Let us look at this now. A 4-year-old boy presented with facial edema, ascites, and scrotal edema. Look, edema is more generalized here. So there is more generalized edema, that is history given. So generalized edema, most likely NSARCA. I am suspecting of what? Maybe if it is a kidney disease, I am suspecting a nephrotic here, isn't it? Urine examination shows 3+ proteinuria. That is enough for me to suspect now what? Nephrotic, isn't it? Clinically, this is fitting into nephrotic syndromes. Nephrotic. There are no CAS seen. That means there are no RBCs, etc. seen. That is also in favor of nephrotic. The child has history of flu-like symptoms 10 days back. So most likely diagnosis. Answer is, my diagnosis, clinical diagnosis is your what? Minimal change disease here. MCD or minimal change glomerulonephritis. Typical history of minimal change, there will be a flu-like symptoms or upper respiratory tract infection happening in the child. Flu-like symptoms will be there, right? Yes. Next, question number 7. In this, okay, image is missing. The images are missing. No, in this image is missing, guys. Sorry. Question number 7. We'll just have to skip this. Okay, anyway, histological examination of a renal tumor in a 5-year-old boy is as follows. So they have given me a history that it is a renal tumor, isn't it? Yeah, it is a renal tumor, and they have given me 5-year. Actually, image was there. Somehow it is missing here. Neuroblastoma, no, it is not a renal tumor. It is an adrenal tumor. Nephroblastoma will be the answer. Angiomyolipoma doesn't occur in children. I mean, rarely. It is a benign tumor. Papillary RCC definitely not in children. It is in adults. So based on that, I'll be ruling out everything. Nephroblastoma. Nephroblastoma is also known as Wilms tumor. Wilms tumor. Anyway, histology should have been given. This is missing in this image here. Next, question number 8. A 12-year-old boy is rejected from college cricket team because the team physio detects ocular lens dislocation. So the 12-year boy is having a lens dislocation. Blood examination is within normal limits. No problem. Urine analysis shows microscopic hematuria. So let us write down what all are features. There is lens dislocation. Lens dislocation is there. Hematuria is there. Isn't it? Hematuria, lens dislocation. Two things. Then younger brother. His younger brother is also having visual problem. Okay, younger brother is also having a visual problem. Okay, so there is a family history. Family history positive, isn't it? Both the parents are normal. Okay, so that means although it is a family history positive, it is not a dominant condition. If it was dominant, then parents, either of the parents should be having a disease. And it could be either autosomal recessive condition or even X-linked recessive condition, because this is also a boy and younger brother is also having, he's also boy. So family history positive. With this I am suspecting query AR or query XLR. Either of them I am suspecting, isn't it? Yeah, I am suspecting either of these two. Okay, a renal biopsy is performed. Okay, kidney biopsy was performed. Microscopically, glomeruli show glomerular capillaries with irregular basement membrane, thickening and attenuation with splitting of lamina densa. This is the keyword given, splitting of lamina densa, very characteristically seen in Alport syndrome. We all studied this. Splitting of lamina densa or basket wave appearance is seen in Alport syndrome, and that is the correct answer. This is not a polycystic kidney disease which is autosomal dominant in inheritance. Marfan syndrome, lens dislocation can happen, but no kidney involvement in Marfan syndrome. Patient should be having, high increased arm span and tall stature, high arched palate, and also aortic regurgitation and aortic root dilatation, that will be seen in Marfan, right? And congenital nephrin mutation. Congenital nephrin mutation is congenital nephrotic syndromes, isn't it? They are congenital nephrotic. This is not a nephrotic syndromes, right? Next, question number 9. A patient presents with hematuria. Kidney biopsy shows a tram track appearance. Immunofluorescence shows deposits of C3. What is a likely diagnosis? There are deposits of C3. What is the likely diagnosis? MPGN type 1. Okay. Important tram track appearance will be seen in MPGN, membranoproliferative glomerulonephritis. There are two types of MPGN, type 1 and type 2. Type 2 is also called as dense deposit disease. I am writing short form DDD, dense deposit disease, isn't it? Now, how do I differentiate type 1 and type 2? Type 1 on IF will show deposits of immunoglobulins and C1, C3, etc. Whereas type 2 will show only C3. That is what will be the difference. So in this, IF shows deposits of C3 only, nothing else is there. That is why the answer will be dense deposit disease. Dense deposit disease. Right? Next, question number 10. Question number 10. Yes, what are we seeing in this question? Question number 10. A patient has presented with oliguria. Okay, patient has presented with oliguria. Then what else history has been given to us? Just a minute. Patient has presented with oliguria. Blood urea nitrogen is 40. So oliguria is decreased urine output. Okay, that is okay. Blood urea nitrogen is increased. Serum creatinine is also increased, isn't it? So basically this is suggesting the patient is having a azotemia. Azotemia. This is azotemia. And query, I would say renal failure. Either a ARF or a CRF. Suggesting, looking at this, it appears more to be what? An acute renal failure, because I don't see any chronic history given to me, isn't it? There's no chronic history given to me. So basically it is a azotemia happening. Question asked is, which of the following can be the cause? So what cause can be there? Acute tubular necrosis, can it cause renal failure? Yes. Rapidly progressive glomerulonephritis, yes, that also can be causing. Renal stones can cause renal stones also. Only thing is, okay, so now what is it? How do we differentiate? If you remember the azotemias, we divided them into three types of azotemias. What are those? One is a pre-renal azotemia, pre-renal causes of azotemia, then renal causes and post-renal causes. We divided them into three, isn't it? Yes, renal, pre-renal, post-renal. So what is pre-renal? Pre-renal will be due to hypotension. So how do we differentiate? In pre-renal, blood urea nitrogen to creatinine ratio is more than 20. Here bun to creatinine ratio 40 divided by 5. Blood urea nitrogen 40 divided by creatinine is 5 is only 8. Yes, it is 8. So this is not a pre-renal cause. Any cause that is there, like yeah, so any cause like yes, so any cause like say pre dehydration, hypotension, etc., they will not be the cause, right? Next is your post renal causes. Post renal causes, again there will be bun creatinine ratio remains more than 20. So even in post renal also it will be more than 20. In renal cause yes, post renal causes more than 20. In the renal causes, there will be bun creatinine ratio will be less than 10. So basically you have to look for whichever is the renal cause that is there. Yes. So in renal cause, okay, renal cause not less than 10. In renal cause, two things. If it is a glomerular cause or it is a tubular cause. Glomerular cause still will be more than 20. Tubular cause will be less than 10. So RPGN is a glomerular cause. That is why it will be more than 20. That is glomerulonephritis. Acute tubular necrosis, that will be the correct answer here. That will be the correct answer. Right? Yes. Next, question number 11. So what is this question? Let me see now. A patient is having multiple petechiae purpura on the skin. Has intermittent abdominal cramps for the last 2 months. So there is multiple petechiae purpura, intermittent abdominal cramps are there. Now presents with reduced urine output for the past 24 hours. Pedal edema is also there. BP is increased. So basically patient is having oliguria and edema, and then there is hypertension also 140/90. Urine examination shows many RBC and RBC cast. So I am definitely saying the patient is having a acute nephritic syndrome, isn't it? Acute nephritic syndrome. Only thing is, this is a part of a systemic disease here. What systemic disease? There are multiple petechiae purpura, abdominal cramps, etc. are there. A renal biopsy is as shown in the image, and immunofluorescence came out to be negative. So what is seen in the image? You can see what is the image here. Look at this. This is your crescent shaped structure. So if you are seeing such a crescent shaped structure, so what is your diagnosis? Diagnosis will be RPGN or a crescentic glomerulonephritis. Important, IF turned out to be negative. That means it is a type 3 RPGN. So it is a type 3 RPGN. Type 3 RPGN are pauci-immune glomerulonephritis like GPA, option C. GPA is Wegener granulomatosis. Even microscopic polyangiitis also can be causing, and Churg-Strauss syndrome can be causing. HSP is a type 2 RPGN. Type 2 RPGN will show granular deposits. Good pasture is a type 1 RPGN. Lupus is also type 2 RPGN. All these are RPGN. All will show crescents. Only thing is IF. IF was the keyword here. IF was the keyword. Next, question number 12. Let us look at this question. A 32-year-old presents with hematuria, headache. Blood examination reveals hemoglobin is 18. Hemoglobin is abnormal, increased. Hemoglobin is increased, definitely polycythemia. So this is looking polycythemia. Good evening all of you. So polycythemia. So what are we saying? Next, TLC is normal, 8,000. Platelet count is 1.6 lakh, also looks normal. Imaging reveals mass in the upper pole of the kidney. So there is a tumor in the kidney as well. Tumor in the kidney as well. Okay. No, previous one was not HSP. In HSP, there should have been one granular deposits, right? Yeah, and it is not even lupus because it should have been granular deposits there also. So answer is GPA, granulomatosis with polyangiitis. Okay, so what is the answer to this question? So there is a mass in the kidney and there is kidney mass is there in a 32-year-old. So, and considering his young age, you start suspecting a familial cancer. Which of the following mutation is likely to be seen? Yes, guys, what is the answer to this question? Please tell me now. What are you thinking here? What is the answer to this question? What are you thinking here? Yeah, what are you thinking here? TSC? No. Tuberous sclerosis will not present with. So patient is having what all features? Polycythemia and a renal tumor. So what do you suspect? Von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome, which will be due to VHL mutation. VHL mutation. So it is not TSC. Right? Yeah, which renal tumor will be there? Clear cell RCC will be there. Clear cell RCC. Next, question number 13. Okay, let us look at this question now. What are we getting in this? A 10-year-old child presents with bleeding per rectum. Colonoscopy shows 2 polyp. Okay, so what all have been given? Always I'll write like this. So patient is, okay, 10 year. There are 10 year and there are polyps. How many? 2 polyps are there, right? In colon and rectum. A polypectomy was done and the histology is as shown in the image. So examiner has given you the histology and based on the histology you should be making a diagnosis here, isn't it? Yes, please tell me now, what are you thinking in this case? What are you thinking in this case? What is the image showing? Image is showing, look at this, there are glands. I can see glands here. Yeah, these empty spaces are glands. And in between this double arrow mark, this is your mesenchymal tissue, that is connective tissue. So this is mesenchymal tissue. I can see muscle maybe. Yes, and this mesenchymal tissue is going and splitting like this. This is what is typical of what pattern we call it? Arborizing pattern, right? It is a arborizing pattern of connective tissue. Yes, where do you see such a arborizing pattern? Arborizing pattern of connective tissue or arborizing appearance that will be seen in a hamartomatous polyp. Hamartomatous polyp, right? So basically it is a Peutz-Jeghers polyp. Peutz-Jeghers polyp. Hamartomatous or a Peutz-Jeghers polyp. Next, question number 14. A 43-year-old carpenter presents with abdominal pain, nausea, vomiting, diarrhea, weight loss of 6 kg in the past 4 weeks. So what all have been given? 43-year, that has been given to us. Then there is GI symptoms. Basically there is what? Diarrhea and weight loss. An upper GI endoscopy shows erythematous intestinal mucosa with white spots in between. A biopsy was done and is as shown in the image. So what are you seeing in the biopsy? Anybody has identified the pathology here? Look at this. This is your villi. Yes. Is there any abnormality in the villus here? No. Villi are appearing normal or villus appearing normal. This is your lamina propria. Within the lamina propria, what you are seeing? These are all foamy macrophages in lamina propria. Foamy macrophages in lamina propria, very characteristically seen in Whipple disease. Whipple disease is due to infection by Tropharema whippeli. Tropharema whippeli. Right? Tropharema whippeli. Gluten sensitivity? No. Gluten sensitivity will be celiac. Celiac will have atrophy or blunting of villi. MTP mutation? No. MTP will show vacuoles within the epithelial cells. Right? Next. Question 15. Next question. Let me look at this. A 28-year male has been troubled by persistent diarrhea for last many years now. So basically, history-wise, it is a chronic diarrhea, isn't it? For many years, he is having diarrhea in 28 year, right? 28-year male. Okay. Every time he visited local doctors, he was treated symptomatically. So he was treated symptomatically, which did not give him much relief. So it did not give. This time an intestinal biopsy was done and is as shown in the image. And this is the intestinal biopsy that was done. Which of the following should be started in him? So what should you treat him with? That is the question asked. Okay, look at this. What you are seeing here. Okay, I am seeing one thing on the top. I am not able to see any villi. I hope all of you are able to see now. So there is villus atrophy. There is a villus atrophy, and in fact this is all crypt hyperplasia. All these are crypt hyperplasia, very characteristic of. So my diagnosis will be what? Celiac. So treatment will be start him on gluten-free diet. If your response, definitely it is what? Celiac only, right? Start him on a gluten-free diet. Okay, yes. Next, question number 16. Gross examination. Yes, gross examination of salivary gland tumor is as follows. Likely diagnosis. What is the likely diagnosis? So this is a gross examination of salivary gland tumor. What you are saying, it is a well circumscribed cartilage-like tumor, cartilaginous tumor, isn't it? So what is your diagnosis? Pleomorphic adenoma. This is a pleomorphic adenoma. Well circumscribed cartilaginous tumor, pleomorphic adenoma. Right? Next is question 17. A newborn was unable to pass meconium. His abdomen was distended. Intraoperatively, the colon appearance is as below. So what you are seeing intraoperatively, this is the colon appearance. Definitely there is a dilated region in the colon. There is dilated region. And also there are narrowed region as well. So there are constricted regions are also present. So what is your diagnosis? And it is in a newborn. I am suspecting query what now? Hirschsprung disease. Hirschsprung disease, isn't it? Microscopic examination from constricted area will show. So what will be there in constricted area? Constricted area, there is loss of ganglion cells or absence of ganglion cells. Because of this, there will be option C. Because of this, there will be no relaxation of this colon. Because there is no relaxation, what will be the problem now? It is not, the meconium is not going to pass, right? In the dilated region, there will be the proximal to the constricted region, and in the dilated region, there will be hypertrophy of the smooth muscle and the hypertrophy of the nerve bundles happening. It is a compensatory hypertrophy that's going to happen. That is in the proximal region. Dilated area will be the proximal to the obstruction, right? Next, question number 18. Special stain helpful in diagnosis of Barrett esophagus is. So what special stain will help in Barrett esophagus? It is a one-liner question. Answer is Alcian blue. Alcian blue stains intestinal mucin. Alcian blue stains intestinal mucin. And this intestinal mucin is required because Barrett esophagus, there is an intestinal metaplasia happening, isn't it? Yes. So intestinal mucin. Prussian blue is for iron. PAS is for acidic mucin or gastric mucin. Methylene blue is for supravital stains like reticulocytes, etc. Question number 19. Gross examination in a patient with diarrhea, weight loss is as follows. Gross examination of stomach. And what are you seeing on gross examination? Look at this. These are what? Mucosal rugae, isn't it? Mucosal rugae. And these mucosal rugae, in fact, is hyperplastic mucosal rugae. I am seeing too many of what? So hyperplasia of the mucosal rugae. Diffuse gastric carcinoma, no. In diffuse gastric carcinoma, there should be loss of rugae. There should be loss of mucosal rugae. H. pylori, no. H. pylori will have ulcers. Sometimes it can lead to atrophic gastritis where there will be loss of rugae. Autoimmune gastritis also will have loss of rugae, isn't it? Yeah, autoimmune gastritis or atrophic, it is called atrophic gastritis, there will be loss of rugae. Answer, Menetrier's disease due to excessive TGF alpha. Menetrier's disease. Okay, question number 20. Gross examination of a gastric ulcer is as follows. What is true about this? Benign ulcer, malignant ulcer, either of them, no ulcer. Of course, it is not no ulcer. I can see an ulcer here. This is the ulcer, by the way. And what you are seeing, these are the mucosal rugae. And mucosal rugae are ending far away from the ulcer. Far away from ulcer. That is why it is a malignant ulcer. Option B, malignant ulcer. Benign ulcer, the mucosal rugae will extend all the way up to the ulcer, isn't it? Good evening. Good evening, everyone. Mucosal rugae will extend all the way up to the ulcers in benign. Right? Next, question 21. A patient presents with diarrhea. Peripheral blood smear shows acanthocytes. Which of the following disease could be causing this manifestation? Which of the following disease could be causing this manifestation? Acanthocytes are very characteristically seen in A beta lipoproteinemia due to mutation of MTP mutation. Okay. Celiac disease can cause folate deficiency or iron deficiency, both of them. So accordingly, they can manifest as a mycocytic or a macrocytic anemia. Ulcerative colitis can lead to, because of bleeding, can lead to iron deficiency anemia. Whipple disease, malabsorption of fat, etc. can be happening then. Next, question number 22. Which of the following is seen in Crohn disease but not in ulcerative colitis? Which is seen in Crohn but not in ulcerative colitis? Transmural inflammation. Transmural inflammation, yes, it is seen in Crohn. That is true. Strictures are also seen in Crohn. Skip lesions are also seen in Crohn. Answer is all of them. Ulcerative colitis will be a continuous. Only inflammation will be in mucosa and submucosa. Right? Yes. Because there is a transmural inflammation, there will be transmural fibrosis and that will lead to stricture. And fissures and fistula are also seen in Crohn disease, not in ulcerative colitis. Next question. Which of the following conditions of GI malignancy is associated with microsatellite instability? Yes, what is microsatellite instability? Where is it? Which condition is associated with MSI? Microsatellite instability is associated with HNPCC or also known as Lynch syndrome. HNPCC. Peutz-Jeghers syndrome? No, it is due to mutation of SKT1 mutation. Then Gardner syndrome is a variant of APC mutation only, familial adenomatous polyposis with multiple osteomas and dermoid and epidermoid cysts. That is Gardner syndrome. Turner syndrome is also APC mutation, that is familial adenomatous polyposis with medulloblastoma of the brain. Right? So Lynch syndrome or HNPCC, hereditary non-polyposis colonic cancers. Hereditary non-polyposis colonic cancer syndrome. Right? Next question 24. Which of the following is the most common malignancy of GIT? Most common malignancy of GIT is colorectal carcinoma. That is the most common malignancy of GIT. Most common mesenchymal tumor of GIT is GIST, gastrointestinal stromal tumor. That is the most common mesenchymal tumor of GIT. Okay. This is a one-liner question. So last question. Let us look at the last question now. Which of the following is true about GI carcinoids? Which is true about GI carcinoids? Ileal carcinoids frequently cause carcinoid syndrome. Yes, this is a true statement, by the way. because ileal carcinoid frequently undergo metastasis and they will end up causing carcinoid syndrome. Appendicular carcinoid frequently cause carcinoid syndrome. It's a false statement. Appendicular carcinoids are asymptomatic, usually do not cause any syndrome. Ileal carcinoid rarely metastasize is also false. They frequently metastasize. Appendicular carcinoids frequently metastasize is also false. Answer is option A. So true about GI carcinoid. Ileal carcinoid frequently cause carcinoid syndrome. That is a true statement. Yes, so these were questions from renal and GIT. So I hope all of you are enjoying these sessions of question discussion, that is the MCQ discussion. These MCQ discussion are going to help you in both PG entrance as well as such a questions are nowadays coming in your exams as well, case-based scenarios. This will help you out, and I hope all of you are reading the or viewing the videos in our app as a second MBBS student, where in detail we have dealt with everything, the concepts of everything. Any doubts, please put forward in the chat box. Okay guys, so I don't see any doubts, then I'll be ending this session. Good night everybody, see you next